and to go ahead and mute. And then when we get to Q&A, we may have a chance to see everyone's lovely faces. Hi, Maria. It's great to see you. Do you mind turning off your camera for the start of our workshop? There we go. We have 3 more people joining. I'm going to give it a couple minutes to get people in. All right. Welcome everyone to our first Lunch and Learn of 2024. It's really the no lunch and learn because we didn't send you gift cards or food of any kind. So we're glad you're giving your hour for us. We will not be disappointed. My name is Michelle Niehaus, and I'm the program administrator for Deaf and Hard of Hearing Services at the Department for Behavioral Health, Developmental and Intellectual Disabilities. Anthony, can you go ahead and start the recording, please? Okay. All right. Great. One of the things I've learned in the past year was that even saying deaf and hard of hearing services can be a misnomer for folks because it groups people in a way that may not be conducive to making sure that they get the services and supports they need. And I learned that from Dr. Scoresby. So today we are going to spend the next hour working with her and learning about hearing loss and mental health access from the perspective of a social worker with hearing loss. Dr. Scoresby is a recent transplant to Kentucky, working at University of Kentucky, and we are so lucky to have her. Our interpreter today is Shannon Greider, who we love, and Jenny James, our amazing CART transcriber. And I would invite everyone to use the chat if they have a question. We'll do questions and answers at the end. You can also use the chat if you have any technical difficulties. It's a rainy day in Kentucky, so internet will hopefully cooperate, but if not, we ask you to use grace and humor, and we will get through this. So as not to take up everyone's time, I would love to have Dr. Scoresby take it away. And I'm going to go ahead and go off screen. Thank you so much for being here today.
Thank you so much for having me. I want to make sure that the volume of my voice is okay for our interpreter and our CART transcriber. So I think we're good. Okay. I am going to share my screen, but before I do, because then it will shrink my image, I just want you to know that I'm so excited to be here. I'm really excited to get to know you and to work with you. I have come to Kentucky to work on research for hearing loss, for mental health and hearing loss. And so I am just thrilled to take this opportunity to share some of the work that I do. Okay, so I'm going to share my screen. And you should be able to see my PowerPoint now. Okay. So as Michelle introduced me, my name is Crystal Scoresby. I currently work for the College of Social Work and have only been here in Kentucky for about 6 months. So I wanted to give you just some information about me so that you know where I'm coming from. So I'm going to share my background and then talk about my research focus and then one of the research projects I'm working on, which is the Living Well with Hearing Loss study. So I have an extensive history with hearing loss. At the age of 4, I was diagnosed with genetic nerve deafness. My mother required the school district to test me. So this was before school testing occurred regularly, and I grew up in California. And so she, because of our family history with hearing loss, she asked them to test me when I was entering kindergarten. And I entered kindergarten at age 4. So that's where it was discovered that I had a hearing loss, but it was diagnosed as mild. And our hearing loss is progressive in my family. Everyone who has it follows the same pattern. So I had speech therapy between the age of 5 and 13. When I was 13, I begged everybody to be done with speech therapy. It was not my favorite thing, but I did that for years. And then at age 12, I got my first pair of hearing aids and I hated them. Put them in a drawer of my dresser and pretended that they weren't there and pretended I did not have a hearing loss until I was 16. And then at the age of 16, decided that I didn't care anymore what other people thought and was curious about what those hearing aids would do. So I opened up that drawer and I put them on. And I have used some type of hearing aid, assistive listening device, cochlear implant since then. So I very much appreciated the volume and the sound that I got when I started wearing those hearing aids. But I continued to lose and lose and lose and lose until hearing aids were no longer helpful. Were no longer able to allow me to accomplish the things that I was doing. So at age 30, I lost all of the rest of my hearing. And then at age 34 is when I got a cochlear implant. So my hearing loss has been with me throughout my life. And it has been something that has been part of my life in my education, in my family, in my social life, in all aspects of my personal life, and working and in a career. So every step along the way, I have made decisions in my life because of my hearing loss. So I just thought I would show you really quickly how extensive the hearing loss is in my family. So this first column, my kids. So I have 3 children. I have a daughter and 2 sons. The next column is me and my siblings. The third column over is my mom and her siblings. And the last column is my grandmother and her siblings. So this is a little bit of a family tree. Everybody in purple has a hearing loss. So that's how extensive the family history is, including my 2 sons. So it's been very much a part of my life and my family's, right? So here's where my career has gone. I got a bachelor's of social work in 2001. It was not my first choice, but it was what I ended up doing because of my struggles to hear. So my first choice was to be an elementary education teacher. And the classes that I was taking, we started to get into this place where we were teaching. And it wasn't teaching children yet, it was teaching our peers. And I struggled to understand my peers. And even though I used accommodations back then, I think things have changed a lot in education the last several years. Maybe I would do things differently now, but then when I could not hear my peers, instead of trying to find a way to hear my peers, I decided there's no way I can be an elementary teacher and hear little children in a noisy classroom. So I need to look into other careers and other majors. And so I found social work and found that I could do social work in a quieter environment, one-on-one or smaller groups, and took an introduction to social work class, loved it, and very much wanted to make that transfer to become a social worker. So I completed my bachelor's degree in 2001. I was strongly encouraged, strongly pushed to get an MSW because there are not enough MSWs. There are not enough people with hearing loss and with deafness who have master's degree who work as social workers. So I strongly encourage, and I'm very grateful for that encouragement, because getting my MSW just opened so many doors for me. And then after several years of being a social worker, I decided to go back to school and complete a PhD. So I just graduated in May of 2023 from the University of Tennessee with my PhD. So that's my education. As far as my employment, what I've been doing, my very first job after getting my MSW, which is a Master's of Social Work, and it was a clinical track degree. So I learned how to be a therapist with that degree in the mental health world. So I first worked with individuals who have learning disabilities, ADHD, autism spectrum disorders. And they were adults that I worked with, but it was a challenge for me. Some of them had very unclear speech, and as a person with hearing loss, it was difficult for me to hear. So I pivoted and worked for an agency in which I did individual and family counseling, and I did that for 9 years. I then opened up a private practice where I continued with individual and family counseling, and and I still continue to do my private practice as well. But it's in those years that I decided that I wanted to go back to school. And so now I also work for the University of Kentucky upon completion of my PhD. So I also teach as a part of my job responsibilities here. And I teach an assessment class. So how I'm help teach other social work students how to assess clients in social work practice. I've taught social work policy and community and organizational practice. So there's a lot of different areas of social work. I don't know how familiar everybody is with social work, but it just is a very, very broad field. Michelle is a social worker, and the work that she does is also considered social work. So there's a lot we can do. So there's really many opportunities in teaching to work with direct students who want to do direct practice, students who want to work with communities or organizations, and students who want to work in policy and government. And so there's just multiple different levels. So being able to have this background in this degree is actually really exciting. Because at any time I could shift it into doing something different and still just really enjoy it. So when I made a shift to research, I wanted to focus on mental health because that's what I had been working on. I had not intended to work on hearing loss and mental health. But when I started my PhD program, the pandemic hit. And when it hit, I just saw so many of my fellow people, my peers with hearing loss and deafness, struggle with masking. I struggled with masking. And in the social media support groups that I was a part of, I didn't just see people struggling with masking, but I saw suicide ideation increase. And so I developed as a side project, a research project to look at what was going on for people with hearing loss as they were facing conversations with masked individuals. That when they had to have mass communication, what was happening to the mental health of individuals who had hearing loss and deafness. I just developed it as a side project. I did not mean it to become my whole pathway. However, the more that I got into this project and the more literature I reviewed and the more work that I did and the more research I looked into, I realized how understudied this is. There is not enough research. We are not represented well in the literature when it comes to how hearing loss and mental health are related. There's some, but it's nowhere near the amount that we should have. And so, of course, who's going to do the work, right? So, of course, I jumped in. And the more I learned, the more I realized what needs to be done. I'm all in now. So, this is what we do know about mental health and hearing loss, that the deaf and hard of hearing people are impacted by psychological distress more so than hearing loss. I'm sorry, more so than those who are hearing. We know this. The literature tells us this. Also, the mental health conditions that those who are deaf and hard of hearing are more likely to have are the more common ones, of course, like major depressive disorder and suicidal ideation, substance use. As a matter of fact, those who are deaf or hard of hearing are 2.5 times more likely to use opioids than hearing individuals. And we also know that those with hearing loss have a lower quality of life. This is what our literature tells us. However, despite the higher risk of mental health disorders and mental health conditions, many deaf and hard of hearing people are not accessing mental health care. And why is that? Some of it is stigma. I think mental health has come a long ways in reducing stigma, but we still have a ways to go. Can be a lack of awareness, excuse me, about how hearing loss and mental health are related and how the difficulties that we encounter on a daily basis can actually cause mental health problems and mental health disorders. We have communication barriers. When we try to seek mental health care, there's a lack of ASL fluent providers in mental health care. And then, of course, there's a lack of acknowledgement from medical providers. Let me just give an example of that. I was meeting with an individual for a research project in an interview, and he was telling me about his experience with masking during the pandemic. And he was describing what to me sounded like a panic attack. So the shortness of breath, the inability to focus, the rapid heart rate, the fear that he's having a heart attack, his heart not working the way it's supposed to work. Like he's perspiring, he's describing these things to me. To me, it sounds like a panic attack. He went to his doctor, went through multiple heart tests and medical exam. At the end of the day, the doctor said, I think that what you're experiencing is anxiety. And that was it. End of story. The doctor did not say, this is how we can treat anxiety. The doctor did not say, we need to give you a referral to a mental health provider. He did not say, there's medication that you can consider to treat anxiety. He just closed the door. He gave the diagnosis of anxiety, closed the door. So this individual that I was meeting with didn't know that there are multiple treatment options available for individuals who have anxiety disorders. He didn't know. So if that provider had told him, you have anxiety and it's treatable, here's some options, that could have been really beneficial. And this happens across the board. So there's multiple reasons why individuals with hearing loss are just not getting the mental health care that they need. The World Health Organization indicates that we should integrate our care, which means we shouldn't take an issue here, like hearing loss, and say, okay, this provider, you deal with the hearing loss. This provider deals with employment. This provider deals with mental health. This provider, right? Because the fractured care doesn't work well. People get lost. So the World Health Organization says we need to integrate. We need to integrate care. What does this mean? It means lots of things, but here's one of the things it means: that mental health providers should not just consider mental health when they're working with clients. They also need to consider what their clients' communication needs are, right? And so becoming culturally aware of deaf and hard of hearing, the individual needs that we have, that's essential. That mental health providers absolutely should become aware. Mental health providers should increase communication access and treatment, and should work towards integrating behavioral health with medical services and audiology services. So this is where my research starts to come in. So one of my focuses is to integrate care between social work and audiology, because many people with hearing loss are already seeking audiology services, but audiologists cannot treat mental health. However, if we can bridge between the two, if we can integrate between the two, then we can help with some of those gaps between hearing loss and resultant mental health issues. So this is the study that I've been working on. This is an example of integrating social work into audiology. This is a project I'm working on with the University of Tennessee in their audiology and speech pathology clinic. So their clinic already provides a course called Living Well with Hearing Loss. And in that course, they provide education about hearing loss. They provide information about using hearing aids or apps for your phone or other assistive technology. They also provide ways to increase your own self-advocacy and how to improve communication, as well as how to do auditory training. So increasing your opportunities to hear. So they already teach this course to individuals with hearing loss. So what we are doing is taking this course and implementing 2 mental health modules. And those mental health modules are designed to increase the mental health literacy of individuals who have hearing loss. So the first module, we talk about how hearing loss and mental health are related, how one impacts the other, and mental health can impact hearing loss. And in a few slides, I'm going to show you a couple of examples of what that looks like in this research project that we're doing. The second module is we give some tips on strengthening mental health, as well as how to work with mental health providers to help increase communication access. So it's a 6-week course. It's an hour to an hour and a half each session. It's designed to occur in a peer group. So there's usually 8 to 10 people max in the group. It's for individuals with hearing loss and their communication partner. And we include the communication partner because, as you all know, how important it is that people in our life understand hearing loss. It's vital that our people understand hearing loss. So this 6 weeks of class is what the research project is. And what we're doing is that we're assessing to see, is it effective? Is it effective to add in these mental health modules into this course that's already happening? Is it making a difference for people with hearing loss so that they can understand more about their own mental health and know how to proceed with mental health care treatment if that's what they need? So we've offered the class 3 times now and we started in person, but it's now on Zoom, and we're currently pursuing a grant to convert these modules into an online program that anybody can access. Anyone in the country, anyone in the world. So that will be some next steps that we're doing. But I just wanted to share a little bit more about what the program is and the results, some of the preliminary results we have from it. I'm just going to check my time here. Okay. So here are I'm moving my little captioning box. My little captioning box on Zoom blocks what I'm reading on the screen, so I have to move it around. So the first module that we introduced is this mental health literacy. These are just some examples of some of the things we cover. So we define mental health and discuss the relationship of mental health and hearing loss. And then we have people reflect on the thoughts and feelings that they have that are associated with challenges of hearing loss. And we give them homework and ask them to come back to the last class, which is the second mental health module. We ask them to come back with some of those thoughts and feelings, and then we practice a couple of mental health interventions. We do an example of cognitive behavioral therapy, and we do an example of mindfulness that they can then practice for themselves in the class based on what they brought. So the difficult experiences or their challenges, and then so that they have something to practice real time to be able to navigate the difficulty that they're facing in a variety of different experiences with hearing loss. And then we talk about how to find and access mental health treatment. So the reason we do real-time examples is because we want to decrease the stigma of mental health intervention. There are so many different mental health interventions, and they previously, historically, have been less accepted than medical interventions. So, you have an ear infection, go to the doctor for an antibiotic. That's pretty well accepted. But you have a panic attack, seeing a therapist, that has been less accepted. So what we're trying to do is we're trying to reduce the stigma that this is what an actual mental health treatment looks like. And we want it to be accessible. We want these treatments to feel accessible to people with hearing loss who are not, especially those who are not familiar with what mental health intervention can look like. So we want to reduce stigma, and we want them to increase their knowledge of how situations with hearing loss can lead to something like a panic attack, or it can lead to something like a mental health problem. So that's the goal of our mental health modules in this intervention. Here's an example of one of the slides that we go over in one of our modules. This is a Canadian mental health literacy model. And we talk about this triangle of mental health, that mental health is something all of us have, just like we all have physical health, right? So mental health is something that we all have. And at what point does it become an actual issue? At what point is it maybe a distress, like that third tier from the top, versus a mental health problem versus a mental health disorder. All of us. All of us experience mental health distress, right? All of us experience mental health problems. Not all of us experience a mental health disorder, but those with hearing loss and those who are deaf have an increased risk of experiencing a mental health disorder. So we talk about the difference between them all, and with people in the group, and what distress would look like versus what a disorder looks like. And one of the things that gives you the most information on to know where you fall in this triangle is how impacted are you? So if a mental health problem, if you're really struggling with distress and it is affecting your sleep, if it's affecting your food or the way you eat, if it's affecting your relationships, if it's affecting your job, if it's affecting your ability to leave your house, the more that it impacts you, the higher up it goes in this triangle, on how much more of a problem it becomes. And the higher up it goes on the triangle, the more likely a person is to need mental health treatment or mental health care. So here's an example of one of the slides that we use. Here's another example. We talk about what mental health disorders are associated with hearing loss. Also, which ones are associated with tinnitus too. So these are all examples of disorders, mental health disorders, that those of us who live with hearing loss, are more likely to experience. Major depressive disorder, generalized anxiety, panic. We've already talked about substance use. Adjustment disorders, for those who are not familiar with that, it's trying to get used to a new situation or setting. So a big move, a divorce, a new job. Those are all times that we need to be adjusting. If we get stuck and it's a struggle to adjust and we just can't seem to adjust, there's a disorder or a mental health disorder called adjustment disorder. That's what that is. OCD, obsessive compulsive disorder, is another one. So we talk about these disorders that are associated with hearing loss. And then we also talk about what people can do to help mental health care be more accessible. So we provide something like this, which is an accommodation list that people can take to behavioral health care, and how to talk to their caseworker or their peer support or their therapist about what the communication needs are that they have. So for example, this says, speak at a natural volume and speed, but use short sentences. And it's asking the therapist to do certain things, and you can circle what you need, you can add to this, etc. So something like using visual aids. So being able to have something like this where you can give to your provider and you can say, this is what I need. In my work with you, I need you to consider all of these things and make sure that we are communicating well. And then what we tell people in our sessions, if a provider is not willing to even read a list or learn more about how to communicate with you, chuck them. Those are not people you need to be working with. We need culturally competent providers, which means they need to do the work, some work, into knowing how to communicate with their clients. They're willing to do some work, we can teach them. Makes a big difference. So we go over this, we give this as a handout and share with them how to talk with a mental health care provider to increase accessibility of some of these treatment centers. Okay. So I'm going to breathe for a second here. I had to turn off my little heater. This is how, now I'm getting to the results part of this. So this is how we are assessing the effectiveness to see if it's making a difference with talking about mental health within an audiology setting. We do interviews. So we are meeting with the participants of the class. We meet with them before the class starts. And then we meet with them after the 6 weeks is done. So after the program is over, we meet with them again. And then we compare their answers, their pre and post answers. So we ask questions in their pre-interview, like, what are your experiences with hearing loss? What are your experiences with mental health? How are they related? And then we ask those same questions following the Living Well with Hearing Loss program. And then we look at the differences between the interviews to see what people are saying. And then we're also using what's called a standardized measures. This first one is an example. This is the Kessler 6 or the K6, and this measures psychological distress. Which is psychological distress is an umbrella term that covers both depression and anxiety. So the question examples are, during the past 30 days, about how often did you feel nervous, hopeless, restless, so depressed that nothing could cheer you up, that everything was an effort, and worthless. And then we do a summary of those scores, and that summary tells us how much somebody is experiencing distress. So that's one example of a measure that we use. The second example is our mental health knowledge questionnaire, the MHKQ. And this is like a list of statements. This is only a part of it, but it's a list of statements, and people mark yes or no if they think, for example, item 1, mental health is a component of health. And if they agree, then they put a yes. If they disagree, they put a no. So there's 20 statements that are just statements that they mark yes or no on. Here's another example. Mental disorders are caused by incorrect thinking, and they put yes or no. Number 6 says most mental disorders cannot be cured. So we give both of these measures to the participants before the program starts, and then after the 6 weeks, after the program ends, and we compare the scores. And that comparison between these items is what helps us to know, is it working? Is the information we're trying to share, is it actually impacting how they feel, their psychological distress? Is it impacting their knowledge? So here's some of our outcomes from the interviews. So participants have commented that this course, the Living Well with Hearing Loss course, reinforced the need for advocacy. And many people, these are just some examples, but many people comment on how important it is that they have peers with hearing loss in this class, because being able to learn from others who are experiencing the same thing is powerful. Here's another example. Becoming more assertive about advocating for myself, not being shy about telling people I'm hearing impaired, and letting them know what they need to do to accommodate me. Another example is the mindfulness intervention that we use. We use a negative thought bubble exercise. And this person said, we really like the idea of popping a negative thought bubble. So they liked the intervention, the mental health intervention that we used. And then this last comment, we loved this feedback because this person said, I'm using areas of my brain that I haven't been used in a while. So with hearing loss, we isolate so easily, and we don't participate in all of the things that would bring us joy or things that we have an interest in. So for this person to start painting again and start attending social events again because of the result of this course tells us that learning about your hearing loss, learning about mental health does help people. So here's the results of K6. This graph over here just shows us the total score, the sum score. And what we want to do is we want to see a decrease in the sum score. And that's what we're seeing. Not a huge difference there, but we're seeing a trend that there's a decrease in the summary score, which means that between the two time periods, before taking our course and after taking our course, that psychological distress slightly decreases. So the trends are going in the right direction. Here's the MHKQ results. So for this one, in this graph, you want to see an increase in the score. So in the pre-survey score, you see that little dot. That's the summary score for everybody who's taken it. And then the post-survey for 6 weeks later, we see an increase in that score. It goes higher. We also want to see that. So the trend is going in the right direction for increasing mental health knowledge. So in summary, this is what we have gathered from this research project, that participants are saying that they have an increased understanding of hearing loss, as well as knowledge of mental health. That's a good thing. We want them to have that. We're seeing so much value in the collaboration between social work and audiology. So it's really interesting because I work really closely with audiologists in this project, and we are presenting our ideas, we're presenting this collaboration, we're presenting our findings in multiple different conferences in Tennessee, in Kentucky, across the nation. And it's been really interesting as we have talked to other audiologists that when I share with them how they can increase accessibility for their patients to receive mental health treatment, I have had people who literally have stopped me mid-presentation. For example, this happened in Tennessee at a Tennessee only. So everyone was an audiologist in Tennessee. And I was sharing with them ways to decrease the gaps. And when they stopped me, they said, do you have enough people who work in your field? And I said, no, not at all. We need more. But why do you ask? And they said, because we do send our patients, when we recognize that our patients are having problems with mental health and they need additional help, we send them to behavioral health care and to therapists. But you know what they're told? And remember, this is like mid-presentation, room full of people, right? And I said, what are they told? And this person says, they're told by the therapist, you have a hearing loss. I can't help you. And I didn't even get the chance to respond in this presentation when another person raised their hand and said, that happens to me too. And a third person in the room raised their hand. Me too. A fourth person stood up. They didn't raise their hand, they stood up. And they said, why are our patients with hearing loss being turned away by you? Talk about a humbling experience, right? Is that here I am representing mental health, and my peers who are providing mental health care services are turning away people with hearing loss. So in this work that we're doing, it's not just on the audiology side. We're bringing it to all the social workers. We're bringing it to all the marriage and family therapists. We're bringing it to the case managers. So the work has to happen on both. So audiologists need to increase awareness of how to help their patients with the mental health challenges that audiologists cannot treat. Mental health providers have to increase their knowledge and awareness of how to work with hearing loss so that they don't turn it away, because that's ridiculous. There are ways to integrate, there are ways to work together. And we frankly should be further along than we are. And all of us are invested in this, in increasing access to care. That's what we're doing. We're increasing access to care because we've got to move. We have got to get people who need services into services, right? So I get a little soapboxy when it comes to that. But the third benefit to our research project, our intervention, has led to changes in the clinic at the University of Tennessee. So they are now using measures to assess mental health distress in their patients, so that when people are coming for a hearing aid fitting or just to talk about hearing loss or a cochlear implant prep or anything like that, then the audiologists are now looking more to see how they're doing with their mental health. This is good. We want this to happen, because if they can recognize the increased risk of people with hearing loss and deafness with mental health disorders, and then do a measure and see the result, then they're going to better know who needs referrals. And because we're trying to integrate care, instead of saying, oh, go see a therapist or go talk to your doctor, it's, oh, you know what? We have a social worker right down the hall. I'm going to go introduce you to them, and we're going to make sure you get connected to resources. So that's what we're trying to do in integrating, and it's already led to a lot of changes in the audiology clinic at Tennessee. I've only been here for a few months, but I'm already working with the audiology clinic here at the University of Kentucky, to where some similar integration will be happening. So this is just kind of a summary of who I am and what I'm doing here in Kentucky. And let me just share again how excited I am to be here, how grateful I am to get to know you and to work with you, and would just love to open it up to see if you have any comments or reactions or questions. So while you're thinking, I'm gonna open up the chat box here. Okay, those aren't for me. So, okay, so if you have any comments or questions, you can feel free to turn on your video or to ask it in the chat.
Hello, my name is Dodie Carr, and I just wanted to make a comment that a lot of hard of hearing individuals in southeastern Kentucky face these kinds of problems. So I feel so good that you have validated that therapists and case managers and audiologists, everyone needs to get behind this plan. So I really look forward to this kind of a change happening if possible. Thank you. Thank you for this session. It was really good.
Jody, it's so good to meet you. Thank you for
Yes,
your
thank
comment.
you.
Okay, and it looks like we've got a message in the chat box here that outcomes could improve with trained peer mentors with hearing loss. More people with hearing loss could be reached. Jeannie, I agree. There are many of us who have a hearing loss. It's not like there's only 5 of us in the state, right? There are thousands of us in the state who have hearing loss. And it is so powerful to be able to network with other people who have hearing loss. Because it's one thing to have a doctor or a professional or an audiologist have a lot of education and learning and training. I'm so grateful for them, so grateful. But it's entirely another thing for a person who faces the same challenges I do every single day to then say, oh, this just worked for me. Have you tried this? That's really helpful. Or for someone to say, oh my gosh, this sucks. This sucks. I need this information for my child's school. And they're not giving it to me because I can't hear them, right? That we can relate to each other. That was just an example. It's always hard for me to hear in my kids' school. So that's always a challenge. But thank you, Jeannie, for that comment. Other thoughts? I'd love to hear your thoughts. And your experiences here in Kentucky too. If you've had the same thing that those audiologists found in Tennessee, if you've heard of or seen people be turned away because of hearing loss. Have any of you seen that?
This is Michelle. We hear reports of it all the time. People are told, oh, I can't treat you because you have hearing loss. And it's so demoralizing for people to finally reach out for help and want that assistance and then to be told they can't get it. So we are absolutely trying to partner. I love your statement and your similar soapbox to mine that, you know, why are people being turned away? And we should be a lot further along than we are in working together. I think that's so true.
I'm disappointed to hear that it also happens in Kentucky, but I'm not surprised. I think this is a nationwide issue. I have a friend who's a therapist with a hearing loss in Arizona, and she had to go to the VA and fight for people with hearing loss because even though the VA is a very large provider of hearing aids, the therapists in the VA were turning away veterans because they're saying, you need to go see your audiologist. I can't help you if you have a hearing loss. And it's not true. It's not true. But what is true is that audiologists cannot treat a mental health disorder, right? So no one can say, go see an audiologist for mental health treatment. That is never, ever something that's appropriate, especially from someone who's a mental health care provider. So yes, we have lots to work on, don't we, Michelle?
We absolutely do. I think about the no wrong door. If someone goes in to get treatment for hearing loss, the audiologists are learning more and more about the mental health impacts. Then having strong relationships with the mental health providers is key, and vice versa. I'm interested in the integrated care model and what we may be able to do together as many of our community mental health centers go towards the CCBHC. It's the Certified Community Behavioral Health Clinic status, where they integrate the mental health care with the physical health care. And I wonder how we can impact people that way. I know at least one of our community mental health centers is prioritizing people with hearing loss in that process right now. So this would be a wonderful way to further that work. And I'm seeing a question from Hillary about the recording. We will be, we are recording it and we will send out a link. If you put, I'll put my email in the group chat, and if you email me, I can send you the link. We didn't have registration for this, so I don't have your emails, but you can email me at the email in the chat and we will send that out to you when it's ready. It'll probably be a couple days before we have it uploaded and ready on our YouTube channel. You can also find our other lunch and learns there. And we are always open to ideas for other topics. In February, we're going to talk about marketing and public relations for people with hearing loss, to make sure that we're reaching people with hearing loss with mental health information and increasing health literacy. And I see at least one more comment that you might want to respond to there, Crystal, from Jeannie.
Oh, sorry. Some people do not seek hearing loss treatment. Right. I can see how it would be hard for our mental health providers struggle to serve deaf and hard of hearing patients. Yes, not everybody with hearing loss goes to an audiologist. So that's not our only pathway to increasing accessibility. It's a pathway, but not the only pathway. So we need to continue to work with providers, mental health care providers, so that anyone who's coming into their doors, we don't turn away. We find a way to help and to communicate with. I am also going to include my email address. If anybody would like to contact me, if you have questions or comments, want a copy of the PowerPoint, you want to take the Living Well with Hearing Loss program the next time we offer it, want to go on my email list for research projects and updates, like anything, feel free to reach out and email me. And it looks like we have another comment from Maria. When I was young, I had an audiologist who tried to force me to get cochlear implants because she thinks it would be better for me. But only I know what is better for my hearing. Absolutely, Maria. I was not ready to lose my hearing yet if I could hear with hearing aids. It upsets me as a child and infected me a little bit. So the way that others treat us affects our mental health also. So that could be actually a really traumatic experience, to go to somebody who you're supposed to trust, and they're trying to force you onto a treatment plan that you do not want or you are not comfortable with. And that's really hard. I've had a similar experience where this was just last year. I have one cochlear implant, and I went to an ENT for sinus issues, not cochlear implant. And he's like, you have to get a second implant. You have to. And I'm like, I don't want a second. You have to get a second. Like, he spent 10 minutes telling me that I had to get a second implant. And I'm like, that's not why I'm here. And he never once talked to me about the sinus issues I was going for. So that was annoying. So all physicians need to increase awareness and sensitivity. Absolutely. Brianna, it's good to meet you. Oh, Voc Rehab Counselor. We love our Voc Rehab Counselors. Awesome. Feel free to reach out to me. So I know we need to wrap up. Thank you so much for letting me be here with you today. And again, really looking forward to getting to know all of you better.
Thank you so much, Dr. Scoresby. We are so lucky that you chose Kentucky, and I can't wait to see what happens in our state with your heart and your brain and your ability to connect with people. So thank you so much for being here and for presenting. Thank you to Shannon, our interpreter, and to Jenny, our captionist, and to Anthony, who was providing behind the scenes support and recording for us. So we hope you enjoyed today's presentation. Please reach out if you have other topics you'd like to see us offer. And we hope that you take this information and talk about it with at least one other person, because that's how we build that knowledge as well. Thank you so much and have an excellent rest of your day. Thank you so much. That was great.
You are very welcome.